bleeding when you went to your dentist? If you did you know that that's a strong sign of the biggest killer, the biggest disabler in the world? Sounds weird, doesn't it? And let me ask you this. If you had bleeding, did your dentist ever say anything about it? Unfortunately, no. It's sort of, for most of us, the answer is no. I had bleeding a good bit when I was younger. And I don't know how many dental visits I've had where my gums were bleeding and the dentist never said anything to me. It's sort of like dentists get boiled in water, like the analogy of frogs getting boiled slowly. Similar to the analogy, similar to what happens with doctors when they come out of medical school training and they want to save the world. And then they have failures in terms of motivating patients and failures and struggles with insurance. And they forget what's most important. Yes, it's important that we have good looking teeth, but it's far more important if something's going on in our body that could be killing us. So today's features, dentists, what are they doing in terms of prediabetes care? We covered part one last week. We'll cover some more items on it this week and hope to get through that fairly quickly so we can get to some question and answer. Previous topics we've covered, osteoarthritis. Many of us don't know that there's links between arthritis and heart attack and stroke. Very strong links between inflammatory arthritis, arthritis to be specific, rheumatoid arthritis, psoriatic arthritis. Those are very, very strongly related to heart disease. Most of us would not have thought, myself included, that osteoarthritis, which is just wear and tear on the joints, would be related as well, but it is. Intermittent fasting, there's still debate about that. Why are we still debating it? Because there was some valid science coming out talking recently about, was it really working? And I'll give you, for those of you who perk up your ears the way I did and said, why would intermittent fasting not show a positive impact? If you looked at that study, one of the major concerns and failures of that study was it was looking mostly at weight loss. It wasn't looking so much at bioindicators. But again, if you'd like a little more detail, go take a look at it. Is type 2 diabetes caused by beta cell destruction or dysfunction? That sounds a little bit geeky, but for those of us who have gone deep into the diabetes world, that's a very, very important question. In other words, are we able to get function back out of that pancreas? 5 supplements that may boost cardiovascular health. Supplements are always a very, very popular item, and that was no exception. Vasipa, fish oil. Is it really better than fish oil? You know, with metformin, with statins, with so many drugs, Big Pharma has found supplements that helped. With metformin, it was called goat wheat or goat something? Some kind of goat something. With statins, they came from a supplement called red yeast rice. With Vasipa, it came from a supplement called fish oil. Are they really that much better? And we cover the details in those videos. The Got Sugar webinar has become a lot more popular. We're also getting better at making people aware of it. Again, if there's one item that people are not getting from their doctor that is and dentist, as we'll talk about today, that is a major killer, a major disabler, it's undiagnosed prediabetes. If you haven't had an insulin resistance profile, you really need to do that. But doc, I'm okay. I know you look at that. I know you're all wrapped around that issue. My doc looks all the time. What is he looking with? Well, about 80% of people in the best medical systems are getting screened for prediabetes. The vast majority of that, as in 80% of that, 64% of the total, are getting screened with fasting blood glucose. That's terribly inadequate. And it's way outdated in terms of medical standards. It doesn't show insulin components. It doesn't show our response to glucose challenges. At least do a glucose challenge. Now, nobody's doing, well, very, very few. It's very unusual to see a glucose challenge or an insulin survey. Of those people that are getting screened, it's either, again, as I mentioned, fasting blood glucose or just a hemoglobin A1C. And what's wrong with hemoglobin A1C? That, you know, all the doctors that are, quote, in the know seem to be going that direction. It's simple, it's easy. Yes, it is simple. It is easy. But here's the problem with hemoglobin A1C. A1C, and look it up. Don't just take my word for it. American Association of Clinical Endocrinologists, the American Board of American College of Endocrinologists, they say the same thing. A1C is not adequate to diagnose this problem. Why? Significant variation with ethnicities, significant variation with genetic differences in hemoglobin, thalassemia, several other different variations there. What about anemias? There are dozens of anemias ranging from microcytic small cell anemia to iron deficiency anemia. And most of those cause differences and changes in A1C. Also, liver disease and kidney disease, both can cause very significant differences in A1C. So A1C is great for using in an individual when you already have made the diagnosis and you know what that person does or does not have. It's sort of like a Libre. It's good for following patterns. It's not good for making a diagnosis. So again, we still have the other webinars out there. Plaque, if you've had your CIMT, and most importantly and most commonly, we get a lot of people that come in and say, Doc, I've had a calcium score and it was positive. What do I do next? And as usual, the supplements webinar is always, always a hot topic. We've got the online courses now that we're getting more information out and available for people. The course popularity's continuing to pick up. The cardiovascular inflammation course has always been a mainstay for us. And again, given the last discussion we had, I've been concerned about people focusing too much on cardiovascular inflammation and not on detection of insulin resistance. And sure enough, that's started to pick up over the past month or two. Speaking of things picking up, the membership programs are picking up significantly. It's an easier way for a lot of people to budget their care, to make sure that they're taking care of their health, especially in these times. The book is finally making some progress. Todd submitted it to the publisher, 2 weeks ago now, and we're looking at cover things and stuff like that, and so we're making progress, and it looks like it'll be another maybe 4 weeks before it comes out. We're starting, as we mentioned before, we're starting to put out chunks of content from the book in our blogs. Speaking of which, it's the website. Again, we went from an old beat up, not very popular website less than a year ago, less than 300 visits per month, to a destination that a lot of people are going to. 2 or 3 months ago, we were over 6,000. Now we have tended to stall at 6,000, and I started looking, even though we're adding a lot more content. Well, here's the thing, and you may see this. We've had a challenge with web speed. So what will happen is it is slowing down, especially on the mobile, on the mobile web speed. So we've got to get that cleaned up. You know what? It's Always something, isn't it? So we've got a brief series going on about health literacy. And again, why this? Because the folks that are listening and keeping up with the content on this channel are folks that do need to step up and acknowledge that for their family, for their peers, for your family, for your peers, you do have a major leg up in terms of health literacy. And that's a problem. Our generation is the worst generation, 55 and older, for health literacy. So we'll cover a couple of quick slides on that. It used to be the patients got information at the doctor's discretion. The web is here now, folks. Now patients are empowered to get information themselves, and it is making a huge difference. Well, contrary to stereotypes that older adults who think the doctor always knows best, older adults are eager to learn nowadays. They want to be in control of their own health. Now, most e-health tools are available on the internet, but some have interactive features that allow people to contact their health providers directly or share information. And here's the issue. There's a digital divide. It's not easy for our generation to learn technology. Older adults and other age groups have challenges accessing the health information just because they don't know how to navigate the web. For instance, the effectiveness and use of many e-health tools are low for many population groups, particularly older adults, because of certain requirements. Michael Wolff, quote, "The disparity between health literacy, older age, and medical understanding may be based on generational as well as cognitive differences." Dr. Eckel says that the processing of health information is intimately tied with sensory processes. Sensory intervention and rehabilitation may have made a difference earlier in life, but they were not easily changed as your parents, your aunts, your uncles, other family members, and folks that you know as they age. As people age, cognitive changes affect the ability to use technology. So again, some of the issues that we're dealing with impact cognition and therefore the ability to learn what people need to know to protect their health. So there are certain requirements: the general knowledge of the topic, for example, diabetes and prediabetes, basic knowledge of hardware and software operations, information seeking skills, for example, how the internet, links, and search engines work. For example, most of our peers still don't know what a snippet is. So health literacy and understanding of health information declines with age, tends to, and that inherent complexity of the healthcare system contributes to the problem. So you've got a complicated web environment, a continually increasingly complicated healthcare environment. And again, as we age, we tend to lose our ability to pick up on both of those. So the next topic for improving health literacy is the last part, ways to improve literacy for older adults. Now, I'll go straight into today's topic. You've got prediabetes. Does your dentist care? Part 2. So one program that can help dentists in prediabetes management is the National Diabetes Education Program. The NDEP is a joint effort of over 200 federal, state, and private sector partners. It was established in '97 by the CDC and National Institutes of Health with a goal to improve prediabetes and diabetes prevention care, awareness, screening, and education, and to decrease the disease impact in the U.S. Let me just make a couple of comments. Again, we're all in the midst of a coronavirus pandemic. Besides the election, which is some short-term focus right now, people have been focused on this pandemic, this coronavirus pandemic. Even in the height of this coronavirus pandemic, more people continue to die and become disabled from diabetes and prediabetes than from coronavirus. And guess what? What really makes you die and disabled when you've got coronavirus infection? More likely prediabetes. So we've got a major issue with prediabetes, and nobody seems to be focused on it, including the doctoral level healthcare professional who is seeing you more than your primary care doc. The National Diabetes Education Program recommendations are based on data provided by government surveys like NHANES. We covered that recently. NHANES is the Health and Nutrition Examination Survey. It's part of the census. Partner organizations like the American Diabetes Association, Academy of Nurse Practitioners, Nutrition and Dietetics, and Diabetes Educators. There's a thing called the PPOD program. It's an acronym. It stands for pharmacists, podiatrists, optometrists, and dentists. All these professionals should be very focused on prediabetes. They are a core component. The PPOD program is a core component of the National Diabetes Education Program. And it's focusing on getting more of a collaborative approach from pharmacists, podiatrists, optometrists, and dentists, because again, podiatrists are seeing feet that are becoming damaged because of nerve damage from even prediabetes, not just diabetes. Optometrists. I did a video, 3 or 4 months ago, where I showed that I have a drusen, which is the singular for drusen, which most of us start developing as we go into prediabetes. In fact, as a 63-year-old with significant prediabetes, to have only one drusen is indicative of significant good care of my prediabetes. And I only have that because this is what I do for a living. The PPOD, the Pharmacy, Podiatry, Optometry program, Dentistry program, aims to engage more healthcare providers in a team approach to treat patients with diabetes. For those of you who are saying, like some prevention doctors that I know, other prevention specialists that I know, not to mention some dentists that I know as well, would say, why pull these people in? Are you asking them to act like doctors? No, we're asking them to do what they trained to do to help to take care of the health of their patients. The goal is not to turn them into doctors. The goal is to help them raise awareness. You know, if you looked at that that NHANES study that we talked about last week, there were what, 22 million people that would find out about prediabetes from their dentist and not from their doctor. Even if their doctors were doing the right thing, there were 22 million people that just were not seeing their doctor, but were seeing their dentist. So the goal is to reinforce consistent diabetes messages across the 4 disciplines, the PPOD disciplines, reinforce self-management, healthy habits, periodic screening, focus on PPOD providers treating patients as well as providing educational services. Recognize that these providers are often the first and sometimes the only point of care for a lot of millions, tens of millions of patients. A PPOD provider may be the first to see a person having a new problem. These care programs include not only the usual care, but other things like A1C, blood pressure control. You look at the ABCs. A is for A1C, B is for blood pressure control, C is for cholesterol control, and S is for smoking or tobacco cessation. Where do you access PPOD information? It's on the CDC's PPOD webpage. It'll take part in PPOD program creating extra burden. Will taking part create an extra burden to dentists? It's not that difficult. Prediabetes prevention care, it should not be a volunteer type of process. In other words, it should not be unpaid, because one of the greatest ways, one of the most effective ways to squelch preventive activities is to not pay for it. If you want to challenge and ask me about that, challenge me about that in terms of dentists, think about what happens with your doctor and the medical profession in terms of preventive services. Preventive services have to do with talking to patients, not not so much writing scripts, not so much doing procedures, not so much ordering the labs. They involve talking to patients. How good are doctors today at those preventive services? Talking to patients, finding out what kind of symptoms the patients have, finding out what patients know about the big potential killers and disablers in their life. So failure to generate any revenue through these services is, again, a great way to assure failure in providing them, just like what has happened to the medical community. And it's already hurting our patients and communities. We're going to cover a brief 1-minute video from Fox 47 News. It's a local news group talking specifically about an example in this area. Gilbert?
You can get more out of a trip to the dentist than just a teeth cleaning or a filling. Fox 47's Ann Perret shows us how one local dentist is working with a researcher at MSU to screen patients for diabetes.
Abdel Karim Al-Dasuki died from complications of diabetes.
He began losing one thing after the other. He lost his sight, he became blind, he lost his kidney function, he went into kidney failure.
Complications his son, Dr. Saleh Al-Dasuki, says don't show up until about 10 years of having the disease, which is why he's working to make sure people know their risk of diabetes earlier in their lives, maybe from a trip to the dentist.
About 2/3 of Americans would visit their dentists on an annual basis, but many of them would not visit their doctors.
So the MSU professor teamed up with Holt dentist Dr. Susan Maples, who created a survey that determines a patient's risk for diabetes without having to weigh them.
Is your waist circumference over 35 for women, over 40 for men? Do you consider yourself more than 10% above your ideal body weight? And then there are other more classic signs like tinglings of the hands and feet, inability to heal quickly.
It's also something she can notice in patients with gum disease.
The mouth is a real window to what's going on in the rest of the body.
500 of Dr. Maples' patients filled out the survey and had their blood tested from a finger prick. The results found 19% of them were pre-diabetic.
That's very significant. And mind you, if we do the study on other populations, perhaps we might find maybe higher percentage.
Because the CDC predicts by 2050, 1 in 3 adults will be diabetic, but a quarter of them won't know it. Ann Perret, Fox 47 News.
The screening is not available at all dentist offices, but the doctors are working to expand the study.
So here we go with questions and answers. Just a quick comment. Those of you who may have picked up, they said, well, they found it in 19% prediabetes. That's a low number. It's a very low number. And they thought it was high. I think that indicates they were probably just looking at fasting blood glucose. That's the sort of thing that you find. Again, folks, even that have an interest in this space will use a faulty screen such as fasting glucose. So, Amer Al-Gayer, hi from Germany. Good evening, Amer. Thank you for joining us. Bart Robinson, good morning. Dave, good morning. James Cantor, blood sugar 109. Thank you for sharing that, and thanks for joining. John Tocho, good morning. Kyle Walker, I've been asked to participate in a 3 to 5 year double-blind semaglutide study for non-diabetic patients with a past history of MI or stroke. Thoughts? Very interesting, Kyle. I'm so glad you shared that. And actually, I had not seen these. I'm glad to see them starting to happen. This reminds me of the TAME study, targeting aging with metformin. Semaglutide is a anti-diabetes drug, just like metformin's an anti-diabetes drug. And in both of these, what they're beginning to say is, look, in the TAME study, they're saying, put it in the water because that's what's, that's the mechanism for what we consider, quote, normal aging, plaque, loss of vision, heart attack, stroke, you name it. With With this study, and I haven't seen that yet, the 3 to 5 year double-blind study for semaglutide, non-diabetic patients, past history of MI or stroke. So obviously what they're saying is, yep, we know what caused that heart attack or stroke, and it obviously wasn't diagnosed. It was prediabetes. So let's go ahead and do a trial of a diabetes drug. Now, whether or not semaglutide is better or metformin, I think, again, we've got to have more studies like this before we begin to understand that space. I think I'm very glad to see studies in that space. Vagabond Sojourner, what should a 2-hour OGTT look like in a healthy person? Is the 5-hour craft better? A couple of things. Answer the second question first. Is a 5-hour craft better? Especially as we age, the 5 hours is very, very helpful. I've seen patients who had not so bad, just maybe like more of a pre-diabetic, moderate pre-diabetic looking OGTT. Once you extend it out 3, 4, 5 hours, they got into blood glucose levels well over 300. If you go back to John Warscheider's videos, I think he covers some of that personally. So again, yes, that happens a lot. Here's the critical difference though, and that is looking at insulin. At least 2 patients per month. I will see folks coming in, again, mostly from this channel, have not so bad glucose numbers on the oral glucose tolerance tests. But when you look at their insulin values, it's taking them 2, 3, a couple of weeks ago, 5 times the amount of insulin to even keep a moderately elevated glucose number. So yes, Kraft insulin survey is far better. We do a similar version of the insulin survey. You can go all the way up to the 3 or 4 hours with Quest. Most people don't want to do that. We get a lot of information in just the 2 hours, but we definitely recommend looking at insulin levels. And yes, for those of us who have a problem and are aging, 3, 4, 5 hours are better as well. Now, what should it look like in a healthy person? Optimum glucose values with a 75-gram glucose challenge would be fasting glucose in the 90s. 90 exactly, not 99. And here's the thing. It gets back to some of the statements we've been making earlier in this discussion. I get plenty of people that start out at 90, and then their blood sugars go way high, as in up to over 200. So a fasting blood glucose alone is not enough. You have to challenge your body's metabolism. That's sort of like saying, I want to know how well I can, how well my muscles work, but never really challenging those muscles against weight. You've got to challenge it to see how it responds. What are the rest of optimum numbers? Let me just run through those quickly. For a 2-hour OGTT, optimum would be 90 fasting, 120 or less for the 1-hour peak, and back to 100 or less for the 2-hour. 90, 120 or less, and 100. Now you'll see much higher levels on the quote normal values on lab exams, but just think about what lab normals are. They are the standard deviation of the population that's out there. And if the population, the vast majority of the population, has suboptimal numbers, that's what you're going to see. So for example, imagine what if there was a lab test for body fat composition. Imagine what that lab test, quote, normals would have been 50 years ago versus what it would be now in terms of the obesity epidemic. So that's a place where, just a warning to be careful about looking at the published, quote, quote, lab normals. Now let's go on while we're talking about this, and let's talk about the optimum for Kraft insulin survey, or the optimum for the insulin values. The insulin values should start out at 5 or less. Fasting, it's also more commonly called basal insulin. The 1 hour peak should, again, in optimum levels, 50 or less, and then back down to 20 or less at the 2 hour mark. And again, I mentioned a few minutes ago, one of my patients who a few weeks ago came in to see me, we looked at her insulin numbers. Her glucose numbers went up to 160 at peak. So that's obviously significant challenges with glucose itself. But her insulin values went over 250 to keep it at that level. So people wonder what, quote, insulin resistance means. It means your body's putting out a lot of insulin and you're just not responding to it. Your blood sugar is still staying high. And both of those are injurious, cause injury. It's been documented. People that have high glucose levels chronically, or even people that keep their glucose numbers fairly low, but it takes a lot of insulin to do it, both of them develop plaque, inflammation, heart attack, and stroke risk. Great question, Vagabond Sojourner. Thank you. It gave me a great opportunity to go down a bunny hole here. John Tocho, once a month I am wearing my 10-day Libre to make sure I am on track with my diet. Well, thanks for sharing that. I had another Libre hater yesterday. It's interesting how people react to it. This person was a known diabetic, and again, his perspective, he interpreted me as thinking that he needed to be wearing a Libre all day, every day, and still doing 5 times a day of finger sticks. And no, I would never say that. Libre is helpful, even if you're doing finger sticks, to understand at least once a quarter, for those of us who are stable, once every 6 months, even once a year, to know what our blood sugar is doing, for example, between midnight and 6 a.m. when most of us are not doing finger sticks. So thank you, John. Thank you for sharing that. James Osborne, I've been diagnosed with a borderline aneurysm. Well, let me go back and just make one other comment. It's not just understanding what your blood sugar is doing at night. Most of us are not doing finger sticks all day, every day. And again, we just need to understand our patterns. Is it the most accurate? Another concern this patient had was he was on insulin, and he said, I can't really use it to the Libre numbers to base my insulin dosages. Absolutely not. It's not that accurate for that kind of utilization. It's more to see patterns. So again, hope that was helpful, and thanks for the comment, John. James Osborne, I've been diagnosed with a borderline aneurysmal dilation, I think, and mild aneurysm of the visual ascending aorta. Visual of the ascending aorta. 3.7 centimeters by 4.1 centimeters transverse dimension. Would following the things discussed be helpful in any way? I'm 64. So many people get this picture that thanks James for sharing this, and I'll just make a couple of comments. Most people, when they hear about an aneurysm of the aorta, they get this image of a balloon that's getting ready to pop, and that's not at all what's going on. In fact, over half of us in the US have some degree of 9p21. Quote, the heart attack gene. Now, why did I go down that bunny hole? 9p21 does impact our the connective tissue and muscle within the wall of our arteries, including the aorta. So anybody with a 9p21 should have an abdominal ultrasound to scan for aneurysm. Aneurysm is actually far more common than people think and that they know. And no, an aneurysm doesn't mean it's a big balloon that's getting ready to pop. It means you've got some risk there and you need to follow it. Typically, they'll follow it for years. Now, to get to your specific question, James, would the things be helpful, the following things discussed be helpful in any way? James, if you've got 9p21, you're also 9p21 risk for aneurysm, which most of us do, as not at 80%, but a significant amount of us, well over 50%. It's also known as a diabetes gene before it became known as the heart attack gene. Or maybe no, it was the other way around. It became known as first as a cancer gene, then as a heart attack gene, and then the other shoe dropped. People began to realize the reason it was causing the cancers that it was causing, the reason it was causing the heart attack risk that it was causing is that 9p21 is a gene for diabetes risk. So, James, I went a long way around to make this, to answer this question, but the simple answer is yes. You clearly, this aneurysm indicates that you've got significantly more risk than even the rest of us in terms of diabetes and prediabetes. So if you haven't had an insulin survey, I would strongly recommend that. In fact, from a health perspective, for somebody with an aneurysm, especially a stable aneurysm like yours appears to be, I'm far more concerned about making sure that they know their diabetes and prediabetes situation. And as we've discussed several times already in this video, you can't do that with the typical testing, your doctor doing fasting blood glucose. Even if your doctor is a little bit more aware of what's going on and is using A1C, that doesn't do it either. You need to get an insulin survey, oral glucose tolerance, fast for 8 hours, get blood sugar and insulin values, drink the glucola, either 75 or 100 grams, test again, half an hour later, 1 hour later, 2 hours later, and as they mentioned earlier, 3, 4, and 5 is often very, very helpful as well. Vagabond Sojourner, does weight drive insulin resistance or does insulin resistance drive weight? Simple, short answer is yes. What did I mean by that? The answer is yes. So insulin resistance does drive weight. You know, you start hearing about the middle-aged spread. We start gaining weight as we get older. Yes, we are slowing down our metabolism a little bit, but if you read books like Why We Get Fat and What to Do About It, read that book. That's actually a title of a book. It's a very popular book, a very good book. Gary Taubes is the author, Taubes, and he goes into this whole discussion of the hormonal reason for weight gain. In other words, we don't really gain weight because we're eating too much. We eat too much because we're gaining weight, and we're gaining weight because of insulin resistance related problems. Back to your question, Vagabond Sojourner. So that's saying, well, maybe insulin resistance does increase our weight. And I would say, yes, it does. But does weight increase cause insulin resistance? Absolutely. You know, we used to look at body fat, not so much specifically weight. If that's all muscle, then, you know, you've got the Schwarzenegger effect and maybe you're okay. The vast majority of us that think we have the Schwarzenegger effect, by the way, don't. But we'll cover that at another point, or if somebody has questions about that. Does weight drive IR? So we used to think that body fat was an inert energy storage material. Nothing could be further from the truth. It is a hormonal tissue. It releases leptin, cytokines, several things, hormonal related items that cause insulin resistance. So if IR drives weight, and weight in turn drives IR, is that a vicious spiral? Yes, it is. Thank you so much, Vagabond. Great couple of comments, questions. Speaking of which, we're starting to get a lot of them. We didn't have quite as many people today because who's going to get interested and excited about me ranting about dentists and prediabetes? But actually, it's really picked up, and we've got the folks that are here are putting out a lot of comments. Let me see if I can keep up. Sylvester Beckles, what are the 5 supplements for cardiovascular disease? Well, I would tell you, obviously vitamin D is one of them. Berberine is one. Bergamot. But I'm going to ask you to go to the content to see the rest of them. Vagabond Sojourner, what's the relationship between IR and prediabetes? I think you wrote that question before I covered it. Preventive health is old school medical practice, the town doctor concept. Yes, it is. And unfortunately, old school's been dead a while. So it's hopefully time for it to rise again. Bill H. Good morning, Dr. Brewer. Good morning, Bill. How are you? Chuck K. Hi, Doc. I've been thinking about doing the carb load before an OGTT. I'm on a strict keto diet. So does it make sense to test without the carb loading to see what happens when I eat carbs normally? Yes, it does. That is a recurring issue, especially for patients on this channel. I had a known pre-diabetic, actually full-blown diabetic, who had a diagnosis of diabetes 2 or 3 years ago, and he didn't do the OGTT. And I asked him why, and he said, "Well, we know I've got full-blown diabetes, and this happens a lot. It's not uncommon." He said, I know I've got diabetes, and yes, I would find out how, the current status. Has it gotten a lot worse? Has it not? But here's the reality. I'm a carb addict. I'm a food addict. And Doc, if you really, really need it, I'll go do it. But I'm just very much afraid of eating carbs for 2 or 3 days. I'm afraid I'll fall off the wagon, and it'll be hell trying to get back on. And so, my perspective for him was, well, the big reason for doing this test is for you to manage your lifestyle, to help you motivate and know what you're dealing with. If it's going to create more danger for you to do that carb load, then don't do it. Now, Chuck K brings up a slightly different question around carb loads for OGTTs or insulin surveys. What do you find out if you do a carb load? What do you find out if you don't do a carb load? What you find out if you do a carb load is a couple of things. Number one, you can compare that to your previous results. So you find out, are you getting worse? Are you getting better? You're staying the same. And as we age, our numbers tend to continue to decline, even if we're doing a lot of lifestyle things to manage that. There are a couple of things that will actually significantly reverse it. One of it is, as we mentioned a few minutes ago, loss of body fat. People that lose 10, 20, clearly people that lose 30, 50 pounds, and folks like Dave that shared with us, he lost 150. You can go from full-blown diabetes to not really having a significant problem in this area by loss of body fat. There's one drug that tends to do that as well. Most of the other diabetes drugs help you manage it, but one drug, pioglitazone, actually reverses that insulin resistance process as well. And I've shared some of that in my own studies. So that's the sort of information you can get from that. Now, as Chuck said, well, what if I don't do a carb load? I go ahead and do the OGTT or the insulin survey. Will that tell me how I'm currently doing if I go on if I go on a carb vacation and eat significant carbs. That's exactly what it'll tell you. One of the key differences, Chuck, that you'll see with or without preloading with carbs is this. It's the phase 1 effect. Phase 1 of the insulin response is stored insulin. Your pancreas, the beta cells, can store insulin when they're not being overworked from a high basal insulin output. If it's 5 or below, then your beta cells are able to store insulin. And so if you're on a routine phase and you're not eating carbs, you're not stimulating that release of insulin. So in that point, if you do what you're talking about, Chuck, you will get a much stronger phase 1 approach, because you didn't do the 2 or 3 days carb loading. You didn't deplete your pancreas of the stored insulin. I'm sort of struggling trying to get that logic out there, but again, as you've said, if you do an OGTT and you don't do the carb loading prior to it, what you will see is your reaction that you normally have if you just do a 1 meal carb vacation. If you do an OGTT or insulin survey and you do the 2 to 3 the carb loading, then what you will get is you'll get that depleted phase 1. You won't get as strong a phase 1 insulin reaction. You'll see more of what you've compared to in the past. You'll see more of what would be going on with your insulin and your blood sugar values if you were not doing a keto diet or taking care of yourself in that way. Great question. I've been meaning to try to get that information out, and you can see why I haven't gotten that out a lot of the times, because I still struggle with trying to walk people through the logic behind that specific question. Thanks again. Bear Dance Chalet. I don't think I've seen your name around. Thanks for the comment. Sent JR product info for new endurance product, dihydroberberine SR, and life extension product. Mimics metformin. Okay, thank you, Bear Dance. As my physician is depending only on A1C and fasting glucose, so will not prescribe metformin. Are these new supplements a good substitute? Berberine and what'd you say? Berberine and I don't know what's in Gera Protect. Berberine helps. Bergamot helps. For those of us who have significant sugar addictions, like myself, Gymnema tends to help. Are they a substitute for metformin? No. These things, some of them do impact the gut biome, like metformin, but we don't really know for sure how metformin and how these others impact the gut biome. We also know that metformin, it appears to many people that metformin's major mechanism is what we call gluconeogenesis. Glucose, sugar, neo meaning new, genesis meaning to make. The liver will routinely make. It's our chemistry factory in our body, and the liver is responsible for making new glucose when we need it. The metformin slows that down. Do berberine and bergamot? Maybe slightly different types of mechanisms. So I don't see those as replacements, Bear Dance, or David Carmichael. Thank you. Vagabond Sojourner, is the HOMA IR a valuable tool to use? I get that all the time. Oh, we're doing everything we need to do. We're doing the HOMA IR. HOMA IR, there are some versions that actually involve what's called an insulin clamp. Most of them don't. Most of them are just a ratio. And yes, insulin clamp it is helpful, but it's really more of a research tool. It's got some danger associated with it, and I don't recommend that as a routine test. most of the HOMA IRs that I've seen are basically just looking at a ratio of fasting insulin to fasting glucose. And let me go back to rule number 1 before. No static number or ratio is going to tell you what happens when it's challenged. I've seen people that had great HOMA IRs and terrible metabolism, full-blown diabetes. So James Osborne, thank you, doctor. Thank you, James. Steve Mitchum, great information as always. Thank you, Dr. Brewer. Well, thank you, Steve. And just a quick reminder is, number 1, I see you're coming in from Facebook. We haven't had a lot of that yet. And that's exciting to see. Number 2, if you'll hit a like, somebody remind the others to go ahead and hit the like button. We appreciate it. Skunk Ape, Doc, is true there are more old alcoholics versus old doctors? Oh, Doc, is it true there are more old alcoholics versus old doctors? I don't get it at all. That one just bounced right over my head. Chuck K, I showed my results from Dr. Thompson's test, and she said, I can order that test. I asked her why she never mentioned it. She didn't answer. What can I say? Bill H, 3 weeks ago, I completed 104 hours water fast. Wow, that's a big deal. I am keto adapted and my glucose readings from my Libre went very low. What glucose level is too low, dangerous during a fast for a keto adapted person? Well, for a keto adapted, gosh, you know, I've seen mine and others get down into the 40s and people really didn't feel that different. Now, here's the issue though. You go back to that other statement that we've made. Is that actually accurate? If you go that low, I would certainly recommend that you check the, do a finger stick, get another number, and I'd get nervous down into the 40s, even if you are full-blown adapted. See a lot of people, and myself included, a lot of times when you're on full-blown fasts, and when, especially during sleep, our blood sugar tends to hit its lowest point of the day, 2, 3, and 4 in the morning, before that cortisol bump that tends to hit us at 4 or 5. And see a lot of numbers in the 50s. Now, here's one thing to remember. You mentioned keto adapted, and keto adapted is critical here. There is a cell nucleus in our brain which keeps an eye on our blood sugar values. As we get more and more into prediabetes and diabetes, we start running hotter and hotter. In other words, our blood sugars continue to stay higher and higher. The nucleus in our brain that reads that gets more and more used to it. And I can tell you, I've seen plenty of people that have significant hypoglycemic episodes in the 60s. So don't assume that there's one number that fits all. Don't assume that that one number for you. I've had significant hypoglycemic episodes in the 60s, low 60s. When I was first getting keto adapted. And again, a few months later, I was in the 50s and just feeling fine. Great question. Bill H, mine went below 40 and then the Libre only said low. Again, be sure and do a finger stick. Check that. Bill H, and I felt fine the whole time. Yep, not surprised, as I mentioned. It's been a great set of interests. A couple of other quick things. Great answers, Doc. Very, very helpful. Thank you. Alejandro Rios. Thanks, Dr. Brewer, for the best information to us who suffered heart attack. Well, thank you, Alejandro. I appreciate the comment, and I appreciate the interest that others have shared. A couple of other, at least one other quick thing, and then we will sign off. Gero Protect, it's 3 ingredients. Okay, thank you very much, David. And thank you guys for your interest today.